Good morning, ladies and gentlemen. Thank you very much for attending the APASOL 2024, the Center of Hepatology. The first session is state-of-the-art lecture chaired by Dr. Motoyuki Otsuka. Please.
Good morning. Welcome to this state-of-the-art lecture. It's early, so not so many audience, but anyway. In this lecture, Professor Kao is going to give a special lecture. He is now a chair professor of the National Taiwan University College of Medicine and Hepatitis Research Center, National Taiwan University Hospital. He graduated from National Taiwan University in 1987, and he acted as the president of Taiwan Association for the Study of the Liver from 2017 to 2019. And he acted as the president of the APASO in 2012. He obtained many academic awards, including APASO Okuda Omata Distinguished Achievement Award in 2019. So personally, I'm looking forward to today's lecture. The title of his talk is Precision Management of Patients with HBV Infection. So please start your lecture.
Okay, thank you very much for your kind introduction, Professor Otsuka. Professor Omada, dear colleagues, ladies and gentlemen. And first of all, I would like to thank the Professor Ashina and the organizing committee for inviting me to the APASO 2024 in this beautiful and ancient city of Kyoto. And my task today is to present the precision and management of patients with HBV infection. I'm Dr. Jiang Gao from National Taiwan University, Taipei, Taiwan. I have nothing to disclose with regard to my presentation. So in the following 30 minutes, I will give the data about what is precision medicine, the overview of HBV infection, and the precision management of HBV infection, and I will give you two examples. And lastly, future perspectives. So what is precision medicine? We all know that it is to understand the disease more, to guide diagnosis and prevention, to develop targeted therapies, and to precisely predict disease outcome to achieve a customized health care for a subgroup of patients. So the precision medicine indeed is a paradigm shift from a guideline-specific therapy to patient-specific ones. And the key driver of precision medicine is the advancement of next-generation sequencing and the multi-omics tools. So the ultimate goal of precision medicines is the personalized medicine. That is one drug for one patient. So this is an example for the precision and the personalized medicines. So for example, the current medicine for specific liver disease, the response rate is around 22%. But however, if we have some biomarkers to enrich the patient populations, then we can use the so-called precision medicine to increase the response rate to 40%. And in the long run, we would like to have the personalized medicines, not just biomarkers, but with other laboratory data, radiomics, and etc. Then we can find specifically a subgroup of patient can respond to the treatment 100%. Of course, this is our dream. So then I will give you an overview of HBV infection, and I know all the audience are experts in this field, so it's just a very brief overview. So we know that the chronic hepatitis B affects more than 250 million people worldwide, and it causes more than 800,000 mortalities, including liver cirrhosis and liver cancer annually. So the current approved antiviral treatment, including the NUCs and the pegylated interferon, which are highly effective in suppressing the viral replications. And the NUCs, the previous data show that it can reduce the risk of death due to liver disease by up to 70%. But however, the viremia may recur following treatment discontinuations, so from 50 to 90%, and some of them even have hepatitis flare, liver decompensation, or mortality. Less than 5% of those treated could achieve the loss of circulating HBs antigens, or we call it the functional cures. In 2016, because of the heavy disease burden of HBV, the WHO called for the elimination of HBV infection as a major public health threat by 2030. Of course not. Of course, we know that it is a long journey to eliminate HBV. So this is the WHO hepatitis B elimination goal. So compared to the 2015 baseline status, they would like to have a 90% reductions of the total instance of chronic hepatitis B, and a 90% rate of HBV diagnosis, and 80% of HBV treatment. And regarding the prevention, the vaccine coverage, 90%, prevention of mother-to-child transmission, 100%, and the blood supply screening, 100%. In Taiwan, all these prevention goal has been achieved. So biologically, hepatitis B virus is a small, this the human DNA virus of approximately 3.2 kilo basis with 4 overlapping genes. So it replicates via an RNA intermediate, the pregenomic RNA. So the pregenomic RNA will be reverse transcribed into the negative strand DNA by using the virus-encoded polymerase with a reverse transcriptase activity. And this unique replication step accounts for most of the mutations observed in the HBV genome. So the long-time evolution of HBV, therefore, lead to the occurrence of HBV genotypes, viral variants, mutants, or even quasi-species. So this cartoon shows the life cycle of HBV replication with the quantifiable viral markers. So the commonly used are hepatitis B surface antigen, HBV DNA, and HBe antigens. And recently, the HBV RNA or hepatitis B core-related antigens has been introduced into our clinical practice. The pathogenesis of HBV infection is mainly immune-mediated, and so the host immunity is a two-edged sword. On one hand, it would like to control the viral replication. On the other hand, it will cause the damage to liver cells. So we can see the hepatitis flare, necron inflammation, and even liver cirrhosis. So the natural history of HBV infection can be divided into different phases. For example, the immune tolerant, immune active, inactive carrier state, e-antigen negative disease, or recently the indeterminate phase, or so-called gray zone. So by using the serology, ALT level, histology, and the integrated HBV DNA, and I just mentioned recently, we can use the HBcIAg and HBV RNA for the differentiation of these clinical phases. So let's go back to our clinical practice. So this figure shows the disease progression of Asian HBV patients. So the infants born to HBV carrier mothers have a high likelihood of becoming chronic infections, but usually with inapparent liver disease. Of those with chronic infection, very fortunately, around 2/3 of them will become inactive carrier state, as I just mentioned, with disease remission and decline of HBV DNA. And 1 to 2% of these inactive HBV carriers may enjoy the loss of surface antigens, that is the so-called functional cure, so with a very favorable clinical outcome. So the antiviral therapy may not be required for such patients at the moment, because nowadays we do not have the cure agent for HBV. And in contrast, 1/3 of them will have chronic hepatitis that may progress to liver cirrhosis and liver cancer with various incidence rates. So these patients have adverse outcomes, and therefore they are in need of antiviral therapy to prevent or delay the disease progression. So the next question is what factors affecting the long-term outcome of our Asian HBV patients? So the previous study over the past maybe 2 decades, we know that there are host factors, viral factors, the environmental or external factors will affect the disease progression of HBV patients. So with these risk factors, several SCC risk scores, because SCC is the worst outcome of a patient with chronic hepatitis B. For untreated HBV patient that is treatment naive. So the most commonly used is the RICHIP score proposed by Professor C.J. Chen. They include 5 important parameters: age, sex, ALT level, E antigen status, and HBV DNA level. And there are other risk factors in association with the liver stiffness measurement or measure of advanced hepatic fibrosis. And regarding the treatment of chronic hepatitis B, this figure shows the long-term nuke therapy has many benefits. For example, we can reach the short-term, mid-term, and the long-term goal. And the short-term goal is the ALT normalization, DNA inactivity, E antigen seroconversion, histology improvement. The mid-term goal include the S antigen seroclearance and the fibrosis regression. Of course, the most wanted outcome is the long-term goal, including the reduction of liver cirrhosis, liver cancer, need of liver transplantation, and the liver-related mortality. However, there are still unmet needs of current nuke therapy. For example, we have a high relapse rate after nuke discontinuation, and even after long-term therapy with profound viral suppression, the risk of SCC still remains around 40% in cirrhosis patients. So are any predictors for this unmet need? So we can have some baseline risk factors for SCC development in these treated chronic hepatitis B patients. The OH, the hepatic dysfunction, the concomitant diabetes, and the advanced liver fibrosis or even liver cirrhosis, male gender, and with some regenerative biomarkers such as alpha-fetoprotein and the PIVGA2. And in the third part of my presentation, I will give you some example about the precision and management of HBV infection. So this is a strategy of precision and management in patients with chronic hepatitis B. And I think before HBV infections, we would like to know the risk and the age of susceptible populations. So we will give the HBV vaccination to prevent the transmission of HBV. And for those with established chronic hepatitis B, we would like to know the prognosis. For example, the response to treatment or those stop treatment with relapse. So the actions include we would like to have the functional cure, or we should stop the treatment safely by using the predictive biomarkers. And for HBV-related SCC, we need to have a risk stratification, and by using surveillance and also the concomitant use of antiviral therapy. So this is a summary of HBV markers for the precision and management of chronic hepatitis B. So we can use these biomarkers to stage the clinical phases I just mentioned. The most commonly used include quantitative surface antigen, HBcRAg, HBV RNA, the viral diversity by using next-generation sequencing, and also the total anti-HBC level. We can predict the response to antiviral treatments, so also use these viral markers. And we can predict the relapse after nuke cessation. I think the most commonly used is the quantitative S antigen level. and how to predict the SCC development. And nowadays, the HBsAg and the HBcRAg have their roles. On the other hand, we would like to predict the functional cure. So nowadays, the HBsAg and HBcRAg are useful. So the first example is about the risk stratification and the treatment initiation for chronic hepatitis B patients. Our very early studies, we used the quantitative HBsAg to predict the spontaneous antigen loss in HBV patients. So this is a favorable outcome, as I just mentioned. So we found that the HBsAg level less than 100 IU per ml at 1 year post-E antigen seroconversion can predict the S antigen loss within 6 years. So by using our SEARCH-B cohort at my center. In addition, the HBs antigen less than 10 is the strongest predictor of S antigen loss in E-negative patients who have a low viral load, less than 2,000 IU per ml, by using our ERADICATE-B cohort. And in this study, by using the ERADICATE-B cohort, we found that the HBs antigen level is an important risk factor for SCC in patients with low viral load. So this is an adverse outcome. So very similar to the REVEAL HBV study by Professor CJ Chen, we found that the higher the baseline HBV DNA level, the higher the risk of hepatocellular carcinoma. But however, in patients with a low viral load, for example, less than 2,000 or less than 200, the risk of SCC was very similar, so 0.17 or 0.19%. However, if we can introduce the HBs antigen into these special populations, for those with high HBsAg more than 1,000, they have a 5-fold increased SCC risk than a patient with a low HBsAg. So 0.33% versus 0.06%. So the S antigen can be useful for the differentiation of patients with low viral load for the development of hepatocellular carcinoma. And the second biomarker is the hepatitis B core-related antigens, HBcRAg. And I think our Japanese colleagues are quite familiar with biomarker. So it is a mixture of HBcAg, HBeAg, and also P22CR. So our study, we found that the HBcRAg level of 10 kilo-unit per ml can stratify the risk of SCC in our e-antigen negative patients with intermediate viral load. That means the viral load is from 2 to 20,000 IU per ml, with the hazard ratio of 6.7 after 20 years of follow-up. Therefore, we propose the risk stratification of liver cancer in e-antigen negative patients by using the commonly used biomarkers, HBV DNA, HBs antigen, and HBcRAg. So in this special population, E-negative with a normal ALT, if the HBV DNA is more than 20,000 IU per ml, they are in the high-risk group. The annual incidence of SCC is around 0.75%. And if the patient is intermediate viral load, then we will check HBcRAg more than 10 kilo-units, they are in the high-risk group. But however, if they have less than 10 KU HBcRAg, so they are in the minimal risk of SCC group, with the annual incidence of SCC is only 0.08%. And for patients with a low viral load, we can check HBs antigen. If the S antigen is high in the intermediate group, with the annual incidence around 0.2%. If the S antigen is low, they are in the minimal risk group. So however, this proposition need to be validated by future prospective studies. So in another study, we also found the HbCIg of 10 kilunit per ml can stratify the risk of cirrhosis. We know that the cirrhosis is the strongest risk factor for the development of ACC. And as I mentioned before, the indeterminate phase, or so-called gray zone, has been increasingly recognized in recent years. And usually, we use the HBB DNA, that's intermediate viral load with nearly a normal ALT to define the gray zone. But what are the role of other biomarkers deserve further attention. So we try to identify this issue. So we also use our eradicate cohort, and in this cohort, around 54% of our patients are in the gray zone. So we stratify the risk of ACC in these gray zone patients by using DNA, ALT, and HbCIg. So in the gray zone patients, if they have a high HbCIg more than 10 Ku per ml, actually their risk of ACC is very similar to the immune active phase. And if this patient have a low HbCIg, so their risk of ACC is similar to the inactive HBV carriers with low HBV DNA and low ALT. So we can use this to stratify the gray zone patient into a high and a low risk. By using this HbCIg level in collaborations with Dr. Hosaka from Japan, we aim to develop the HbCIg-based risk score. We call it EXPLORE to predict the ACC in e-antigen negative gray zone patients. So we have two cohorts. The derivation cohort is from Taiwan, and the validation cohort is from Japan. So the EXPLORE, or we can call it the gray zone ACC risk score, include the age, sex, platelet count, ALT level, and HbCIg level. So our gray zone ACC risk score perform better than the traditional RICH-B and the GAG ACC score to predict the 10-year ACC risk in our e-antigen negative gray zone patients, as shown in this right-hand side. So in these two figures, this is a derivation cohort from Taiwan, this is a validation cohort from Japan. So we use the score of 8 stratify the gray zone patient into high risk and the low risk. So as I just mentioned, so the high risk is very similar to the immunoactive chronic hepatitis B patients. So with this data, we propose the algorithm for the precision management of HBV patients by using HbCIg. So in the gray zone, if the HbCIg is high, this patient may need antiviral therapy earlier, even they have a normal ALT at the moment. So the other interesting finding is also regarding the favorable clinical outcome. So in our recent data published in Gastroenterology, we found that the low HbCIg correlates with the higher spontaneous antigen loss in our patients with a high HbSAg, that is more than 1,000 IU per ml. However, we found that it takes a long time, maybe 10 to 14 years, to have a loss of HbSAg before the undetectable HbCIg. We know that the HbCIg may reflect the transcriptional activity of cccDNA. And so when the cccDNA is suppressed, it may take long time. That's because the integrated form of HBV DNA in the host genome. So from this data, we can speculate to reach the functional cure by using the current antiviral therapy is not very easy. The second example is the prediction of ACC in treated patients. So this the paper by Professor Hosaka. He showed the impact of HBCIAG on ACC risk in new treated chronic hepatitis B, either E antigen positive or E antigen negative patients. So in addition to the viral biomarkers, there are also some biomarkers to predict ACC or correlate with the fibrosis severity. So I think the Japanese colleagues are also quite familiar with the M2-PPGI. It is biomarkers for liver fibrosis. And this figure shows this alter M2-PPGI during fibrosis progression. And by using these novel markers in Taiwan, we studied how the baseline M2-PPGI level can stratify the risk of ACC in our chronic hepatitis B patients with oral antiviral therapy. And in this particular study, we found the ACC risk can be stratified by using the baseline M2-PPGI level of 1.73. In our last study, we used the M2-PPGI level at the virological remission to predict the risk of ACC in cirrhosis patients and also mortality. So in this study, the M2-PPGI more than 3 at viral remission can predict ACC occurrence and also the mortality after 5 years of follow-up. We also used the derivation cohort. And lastly, I may give some future perspectives. So now we are in the era of artificial intelligence. So how can we use this artificial intelligence for the clinical application of hepatology? I think we can combine the routine clinically and the laboratory data, the radiomics, the pathology-based image recognition, multiomics, LLM, there's a natural language processing, and also the real-time bio monitoring together, trying to do a better job for hepatology and our liver disease patients. So this is an example from Korea. So they use the AI-driven model for HBV-related ACC in a patient treated entecavir or tenofovir. So they use the machine learning approaches. They have a Plan B model. So it contains several factors: cirrhosis, age, platelet, antiviral, sex, ALT, DNA, albumin, bilirubin, and HB antigen status. So this is a derivation cohort. And they have 2 external validation cohorts, one from Korea and one from Caucasians. So their data show that the Plan B model outperforms other traditional risk scores in predicting ACC. My colleagues, Dr. Donghong Su, also proposed a personalized risk score for ACC using the routine sequential laboratory test and the deep learning. We call it the deep STI model. So this STI model is useful for different etiologies like HBV, HCV, cirrhosis, or even NAFLD or so-called MAFLD. And it outperforms other traditional risk score like RICH-B and the PAGE-B score. But however, all these proposal or algorithm need to be validated by further prospective studies. So how can we use the AI in HBV management? So in our recent review, we suggest the AI may be helpful for the diagnosis, disease classification, the antiviral selection, hepatitis prediction of ACC, and also the evaluation of liver fibrosis. But there's still a challenge ahead of using artificial intelligence in clinical medicines. So in terms of the data, the algorithm, and also the clinical application. So more studies need to be done to solve these very important challenges. But there are also opportunities. If we can overcome these challenges, we can have a bright future by using AI in clinical hepatology. So with this, finally, I would like to thank my team members at the National Taiwan University Hospital and also the patients who participated in our previous clinical studies. And of course, we are going to have the Apostle Single Topic Conference on NAFLD in this June. And next March, the Apostle 2025 will be held in Beijing and hosted by Professor Lai Wei. So with this, thank you for your attention.
Thank you very much, Professor Kao, for your clear and insightful lecture. So, is it okay to take some questions, Professor Kao? Okay. Is it
No problem.
Okay.
No problem.
So, are
My
there
pleasure.
any questions from audience? Oh, Professor Mott.
Thank you very much.
Thank you.
Excellent as always. But there is a long-lasting question that, we have integrants, and we are trying to eliminate the circulating HBsAg, but it's obviously derived from two different pathways. One is integrants, one is cccDNA episomal ones. And so nobody ever checked which one is from which. But by the data you showed, maybe if you test the HBC antigens, C antigen may be derived from the episomal pathways. And then integrants may include both. And your data clearly show, and then you publish in the gastroenterology, that declining fast occurs on the HBC AG. And then that's sort of the expected because nucleoside analog doesn't do anything for the integrant. So it's quite interesting, and then may answer a part of the long-lasting question from my side. And the thing is then, but at the end, if you take two simple things like predictive value of HBC AG and HBsAg, I don't know how to do it, but which one influence more? And by knowing that, maybe integrants' meanings can be resolved. Also, that's the long-lasting questions. So can you answer that?
Okay, there's a $6 million question. We always think of these issues. Yeah, HBsAg can derive from the cccDNA, also the integrated HBB DNA. But in EIG negative patient, most of the S antigen may come from the integrated form. So we use the HBsAg, which reflect the cccDNA activity. And there maybe have some different structures between the S antigen from cccDNA and from the integrated form, maybe due to some post-translational modification. But so we need to collaborate with some chemistry guys to identify or clarify the structure. If we can perform this, then we can maybe a clear differentiation. So what is from this integrated form and what is from the cccDNA. And nowadays we can use the ratio between S antigen and HBsAg, trying to find some rules to offer indirect, not direct comparison. So we will do it.
There is so much on data of the integrant structure, because some of the integrant structure is completely losing the epitopes detected by the antibodies. In other words, even though they are and the protein produced, but maybe they are lacking epitopes against the measurement or the routine measurement of the HBsAg. So I think those are the unresolved. So far, to my knowledge, it's unanswered yet, but it's just of interest, for us.
Yes.
Of course, we see patients still, but maybe that's ending up unanswered forever.
Okay.
That's my impression.
Yeah. Thank you very much for your precious comments and suggestions. Thank you so much.
Thank you very much. So we are out of time, so we have to close this lecture. Thank you very much for
Thank you,
Professor Kao.
Professor Otsuka. Thank you. Thank you, everyone. See you next year.
Good morning, dear colleagues. So today we will discuss with us the state-of-the-art lecture from Dr. Norihiro Kokudo. He is the president of National Cancer Center for Global Health and Medicine in Japan. Dr. Kokudo earned his MD in 1981 and then PhD in 1988 at the University of Tokyo. From 1989 to 1991, he stayed at the Department of Surgery, University of Michigan, as a visiting research investigator. After 6 years at Cancer Institute Hospital, Tokyo, as senior staff of GI surgery, he joined Department of HBP Surgery in the University of Tokyo and became professor and chairman in 2007 until 2017. Dr. Kokudo has been conducting a number of research projects on surgical treatment of HCC, colorectal liver metastasis, and living donor liver transplantation. As a chairman of the guideline committee, he compiled the third and the fourth version of Japanese clinical practice of guideline for HCC in 2013 and 2017. Dr. Kokudo is currently president of Asia Pacific Primary Liver Cancer Expert Association, APAL, and past president of Japan Surgical Society, International Hepatopancreatobiliary Association, Asian Pacific Hepatopancreatobiliary Association, and Japan Liver Cancer Association. He is also a fellow of American College of Surgeons as a governor and Royal College of Surgeons of England. He is a co-editor-in-chief for Global Health and Medicine and associate editor for liver cancer. He is on the editorial board of Annals of Surgery, Journal of American College of Surgeons, World Journal of Surgery until 2021, and Journal of HPV Science. He also received honors and rewards from the Lorenzo Capuzzotti Award in 2015, Second Grade Service Medal from Vietnam 2018, Honorary Medal from Ministry of Health Mongolia 2019, and a PBA Distinguished Service Award 2019. So please, Dr. Norihiro Kokudo, proceed.
Thank you, Dr. Renogani. Thank you very much for your kind introduction. Good morning, ladies and gentlemen. And I would like to thank Professor Omata and Shina and the organizing committee for this great opportunity to give a talk at the APASO 2024. Today, the topic of my talk is the role of liver resection in the era of advanced systemic therapy for hepatocellular carcinoma. And here's my disclosure. And the recent dramatic progress in the systemic therapy for hepatocellular carcinoma provides us the possibility of combination of surgery and systemic therapy. That is adjuvant, neoadjuvant, and conversion settings. The first type of combination is adjuvant setting, systemic therapy after liver resection. And it is well known that tumor recurrence is very common even after curative liver resection. Reported 5-year recurrence rate was as high as 70 to 80%. And there have been a number of trials of adjuvant therapy to solve this issue. There are two peaks of RFS hazard after liver resection. And the first peak is recurrence because of residual micrometastasis. And the second peak may be because of so-called multicentric carcinogenesis. And adjuvant therapy is targeted to lower the first wave of recurrence. This is probably one of the oldest and milestone studies showing the impact of adaptive immunotherapy reported from the National Cancer Center, Japan. They used autologous lymphocyte activated in vitro with recombinant interleukin-2 and antibody to CD3. And after 2 weeks of culture, they obtained sufficient amount of T cells with CD3, 4, and 8 markers. And primary endpoint was met, and this immunotherapy significantly reduced the risk of tumor recurrence after resection. However, this adaptive immunotherapy was not accepted generally because of the complex procedure and probably the cost. And after this study, there have been at least 3 studies testing adjuvant therapies after curative resection or ablation. Intervention for the first one was Russell-Tegafur, UFT, an oral chemotherapeutic drug. And the second one was sorafenib, and the third one was palatinine, systemic retinoid that may induce apoptosis and differentiation of liver cancer cells. And all studies were negative in reducing tumor recurrence. UFT study was conducted at the University of Tokyo, and RFS curves were almost identical between UFT and control arms. And however, if you look at the OS curves, survival looked even worse in UFT arm with p-value of 0.08. And we could conclude that UFT is not recommended after an adjuvant therapy after liver resection. And this is a very famous STORM trial testing use of sorafenib in the adjuvant setting. And target population was patients with moderate risk of recurrence, and sorafenib was administered as long as 4 years in experimental arm. As you know, both RFS and OS curves were almost overlapping, and the study was negative. And it was very notable that 5-year OS was as high as 70%, even for placebo arm. So here I would like to summarize why previous adjuvant trials failed for HCC. First, it was difficult to define optimal patient populations. Outcome of the control arm has been generally too good in previous studies. And there have been no biomarkers for patient selection. And secondly, there has been no established duration for adjuvant therapy. And compared to other cancer types, peaks of the hazard curve for recurrence are not very steep. And progression of tumors and liver dysfunction may accompany in most of the cases, and severe adverse events is not acceptable for seemingly healthy patients after curative treatment. And finally, I guess previous studies were just insufficient in efficacy. After the introduction of immunocheckpoint inhibitors, at least 4 phase 3 trials are ongoing for hepatocellular carcinoma in adjuvant setting. And experimental arms are nivolumab, durvalumab, bevacizumab, pembrolizumab, and atezolizumab plus bevacizumab. And inclusion criteria for these trials are high risk of recurrence patient subgroup. So macroscopic vascular invasion may have been regarded as very high, not high of recurrence. So this patient's condition was excluded in the 3 studies of this table. And only in Brave 050, a study of atezolizumab plus bevacizumab, accepted VP1 or 2 patients. And these ongoing studies may provide important evidence for the impact of adjuvant systemic therapy after resection or ablation for medium or high risk of recurrence patient subgroup. However, we cannot expect conclusive evidence for the use of adjuvant immunotherapy for HCC with vascular invasion. Some of the peaks, since the peaks of HCC recurrence are very broad, it is difficult to define optimal duration of adjuvant therapy. For most of the cancers, including pancreatic or colorectal cancers, hazard of recurrence is the highest in the first year after curative resection. So the target period of adjuvant therapy is generally the first 6 or 12 months after resection. If we compare the duration of adjuvant treatment in the previous HCC trials, it varies a lot, from 6 months to 4 years. That suggests no established duration for adjuvant therapy for HCC, and it was set 1 year in the recent ongoing trials using immunocheckpoint inhibitors. Very recently, in Brave 050 study showed significant better RFS for adjuvant atezolizumab bevacizumab. And this is the first phase 3 study showing the benefit of adjuvant immunotherapy after liver resection or ablation. However, it is considered premature to conclude on survival benefit. In Brave 050 study, is the only adjuvant study that included patients with limited vascular invasion, VP1 and 2. However, there were only 6 to 8% of cases, and subgroup analysis was done only for cases with micro instead of macrovascular invasion. So we may need further evaluation on the impact of immunocheckpoint inhibitors after liver resection for HCC with macrovascular invasion. Another possible combination of surgery and systemic therapy is neoadjuvant therapy or for potentially resectable cases or conversion strategy for oncologically unresectable cases. Conversion strategy for unresectable colorectal liver mets was established more than 10 years ago. And after the introduction of FOLFOX, FOLFIRI, or monoclonal antibodies, we could expect remarkable tumor shrinkage like this, making unresectable tumors to resectable ones. Morphological changes after systemic therapy for HCC are slightly different in that they present a change of vascularity and tumor shrinkage. Since lenvatinib was approved in 2018, there have been several reports on effective cases. Now, this particular case initially had a large tumor in the right liver and a lung metastasis. And after lenvatinib administration, there was a remarkable shrinkage of the tumors and the metastatic lesion in the lung disappeared. So finally, this patient could undergo curative liver resection. Now, this is our recent case, a typical case of ACC with tumor shrinkage after the systemic therapy. So the relatively high response rate of lenvatinib led us to plan a neoadjuvant trial for technically or oncologically unresectable ACC. There are 5 categories for patient inclusion. And category A is cases with macrovascular invasion, followed by category B, synchronous extrahepatic disease, and category C is a combination of A and B, and category D is cases with very large tumor load where alveolar resection is unlikely, and the last category E is metachronous extrahepatic disease. And a total of 49 cases were recruited, and the most common tumor condition was A. So it is presence of macrovascular invasion. And this is a flowchart of 49 cases, and of the 42 cases with oncologically unresectable ACC, 32 cases could undergo liver resection after lenvatinib treatment. However, only 1 out of 7 technically unresectable cases could undergo liver resection. The median follow-up period was 9.3 months, and the 1-year survival rate was 75%. And the median PFS was 7.2 months. And this is the overall survival stratified by the resectability. And although we may need longer follow-up, you can see a favorable OS for resectable cases. And there's a similar study going on in Japan, neoadjuvant atezolizumab and bevacizumab. Inclusion criteria is the same as those for lenvatinib trial. And patient recruitment has just been closed after registering 52 patients. And recently, Professor Kassev and MD Anderson Cancer Center Group have done a prospective study in perioperative setting to compare nivolumab and nivolumab plus ipilimumab, the blockade of the PD-1, PD-L1, and CTLA-4 pathways. And this may be so far one of the very few clinical trials for the use of dual immune checkpoint inhibitors for perioperative therapy, systemic treatment before and after surgery. Although efficacy was not a primary endpoint, you can see some patients with main pathological response, MPR, measure pathological response, MPR indicated in red. And 29% of cases showed CR, and there has no delay of surgery because of severe adverse events. And patients with MPR showed significantly better RFS after liver resection. In the field of pancreatic cancer, concept of borderline resectable tumor, BR, has been well established. And neoadjuvant therapy is usually applied for BR cancer, BR pancreatic cancer according to NCCN guidelines. And recently, Japan Liver Cancer Association and the Japanese Society of HPV Surgery created a joint work group on so-called borderline resectable ACC, and I happen to be a chair of this work group. First, we conducted a questionnaire survey on expert Japanese HPV surgeons to clarify perception of the resectability of SCC. And then we hold an expert panel meeting to form a consensus on oncological resectability for advanced HCC. And we refer to the results of the questionnaire survey and available evidence published in the literature. And this is a list of expert panel members, and I would like to take this opportunity to express my sincere appreciation. And here are our definitions for R, resectable, BR, borderline resectable 1, and BR2, borderline resectable 2. So surgery may offer clear better survival outcomes compared to other treatment for category R. And surgical intervention as a part of a multidisciplinary treatment may offer survival benefit for patients with BR1. And efficacy of surgery is indeterminate, and surgical indication should be carefully determined under the standard multidisciplinary management for patients with BR2. So for BR1, expert panel meeting took place several times, and we reached a conclusion on tumor conditions for each category. And here are tumor conditions for our category: solitary lesion with no size limit, or multiple tumors up to 3 nodules, each smaller than 3 centimeters. And there should be no microvascular invasion and no extrahepatic disease. And for BR1, there are 3 types of tumor condition: multiple lesions exceeding the R criteria, but no more than 5 nodules and 5 centimeters in diameter, or macrovascular invasion up to VP2, 3, VV2. And localized extrahepatic disease is also included in this category. Localized means technically easy to resect. And BR2 status is considered as initially unsuitable for resection. And multiple lesion more than 5 nodules or more than 5 centimeters in diameter. And major macrovascular invasion or extensive extrahepatic disease are also considered BR2. So these are schematic drawings to demonstrate the definition of R, BR1, and 2. And the figure in the right illustrates the relationship between size, number, and resectability. These definitions may be useful in selecting the patient population suitable for adjuvant or neoadjuvant treatment studies in the future. The results of the questionnaire survey have been accepted to the Journal of HPV Science, an official journal of Japanese Society of HPV Surgery. And the second part, our definition of borderline resectable HCC, has also just been accepted to the Journal of Liver Cancer. And lastly, the third step of our project is validation. And we will analyze the latest data of the nationwide follow-up survey in Japan and validate our consensus on the HCC resectability. And also, it will be interesting if the validation is done using registry data in other Asian countries. So in conclusion, ladies and gentlemen, recent dramatic progress in systemic therapy opened the era of a combination strategy for HCC. And several adjuvant trials using immune checkpoint inhibitors are ongoing, and in BRAVE 050 demonstrated a promising clinical benefit. And neoadjuvant or perioperative systemic therapy for advanced HCC is another clinical question that warrants further investigation. And the definition of resectability or borderline resectability may be a useful tool for future clinical trials. So I would like to thank all members of the expert panel on borderline resectable HCC. And my special thanks go to core members of the group, Professor Tanabe, Dr. Akahoshi, and Shindo. And lastly, I would like to welcome many of you to participate IHPBA 2024 World Congress in Cape Town. So thank you very much for your kind attention.
Thank you, Dr. Norihiro Kokudo. Due to the time, I think that we will have one questions from the floor. If there are any questions. I just wonder, you don't put the liver function in the resectability of these patients. Why?
Yes, it is a very important question. We have to say, our target is technically resectable and functionally resectable. So we are discussing about we can do the operation right away, but probably the combination of systemic therapy may improve the outcome. So these are our target population. Thank you.
So, thank you very much, Dr. Norihiro Kokudo, for the excellent lecture.
Thank you.
I will close this session. Thank you very much.